Hello, students. I wanted to give you some feedback on your heart failure case study that you did probably a while back, but I thought I would give you some feedback just to help you understand the heart failure case study. Okay, so we're going to go through the questions. Some of them you did really well on, and then some of them I want to give you some feedback to help you understand. So the first question talks about what type of heart failure does MW have? So majority of you answered this correctly and said that MW has left-sided heart failure. But let's talk about the why behind it, okay? So let's first talk about blood flow of the heart. So we have to understand the physiology of the heart. And if we don't understand that, it's going to be very hard for us to understand heart failure, okay? Because heart failure has to do with the pump of the heart, okay? So it has to do with the muscle. The muscle is somehow damaged. And there are many reasons why people get heart failure that you've read about in Honan. So let's first talk about the blood flow. So blood flow of the heart, the blood comes in through the superior and the inferior vena cava. That is considered venous blood, so it's blue. And it comes in through those big veins and it goes into the the right atrium and then down to the right ventricle, okay? And then it goes out through the pulmonary vein to the lungs, okay? And it gets oxygenated, okay? And that's where oxygenation takes place. It comes back in through the pulmonary artery, in the left atrium, down to the left ventricle, and then it pumps out through the aorta, to the whole body. Okay, so it goes up to your brain, it goes down to your legs, and that's how the blood flow of the heart goes. So if you think about this patient and what's going on with this patient and why the patient has left-sided heart failure, you have to think about, and I kind of explain this by looking at page 457 in your Honan book, okay? On page 457, they talk about the comparison between left and right-sided heart failure. So let's start with left-sided heart failure, knowing that MW has left-sided heart failure, okay? And what happens is left-sided heart failure leads to pulmonary congestion because the blood is backing up from the left ventricle to the left atrium, back through the pulmonary artery and into the lungs. And when it gets congested and there's blood in there, you start to develop what's called crackles, okay? And how that happens is the left ventricle can't pump the blood out of the ventricle effectively into the aorta, which is what's supposed to happen. And there's a systemic circulation problem, okay? So the pulmonary veins, the pulmonary venous blood flow and pressure increases, okay, because of the left ventricle not being able to pump. So the blood is literally just pushing back through that pulmonary artery, okay? It's pushing back, okay? And it forces the fluid from the pulmonary capillaries into the pulmonary tissues, through into the alveoli, causing pulmonary edema, which is considered impaired gas exchange, okay? Because what happens is when you have left-sided, is you start to have symptoms like impaired gas exchange where you're not getting good oxygenation and your blood and your lungs are not able to inhale and exhale because there's too much fluid in there, okay? So that kind of explains left-sided heart failure and what's going on with this patient and the why that she has pulmonary or has left-sided heart failure. She also has a history of having an MI. So you know that having an MI, there's certain parts of the heart, the muscle is dying. So just from assumptions and just reading on this case study, you can kind of come to an assumption or assume that the patient probably has some kind of left ventricular muscle damage, and that's probably from one of those arteries that was probably occluded and caused her to have a myocardial infarction. Okay, so hopefully that kind of explains it. Right-sided heart failure looks very different, okay? And right-sided heart failure has to do with the right ventricle pump failing, leading to congestion in the peripheral tissues, okay? So what happens is that blood backs up into the peripheral tissues, okay? So that's why you would see someone with edema. That's why you would see someone with weight gain. That's why you would see someone with hepatomegaly. That's why you would see someone with abdominal distension, or you would see a patient with jugular vein distension. If you have a patient who has heart failure in the clinical setting, I highly encourage you to really look at the symptoms, look at their assessment, look at what you're seeing in the patient, because it really helps it to become more understanding. You'll really get to visually see it. And a lot of nursing students are visual learners, and that's why clinical is a great place to be able to see that. Okay. So let's go on to question 2, which a lot of you got this correct, and you thought about what the risk factors for heart failure are for MW. MW had some pretty good risk factors. Okay, she had a history of diabetes type 2 that was diagnosed 3 years ago. She had a myocardial infarction in 2012, and she has a high BMI. Okay, so you can tell her weight is 200 pounds, but her BMI is greater than 30, which would consider her to be a high BMI. Okay, so just keeping all that in mind, now you can see why at some point she developed an acute exacerbation of heart failure. Okay, so let's go on to question number 3, and this talks about clinical manifestations of heart failure. Okay, and I'm going to first talk about left-sided heart failure because that's the one that MW has. So you're only given so much information in this case study. So you're given some very, very important information and cues, or I call them cues or clues, okay? So when I read on her basic assessment, the first thing that stands out to me is she is short of breath on exertion. So I don't know how much exertion. I don't know if she's short of breath just walking to the bathroom 5 feet. I don't know if she's short of breath walking 20 feet down the hall. All I know is that she's short of breath. So if I was her nurse, I would be asking her, how far can you walk without becoming short of breath? Okay. Or how far can you walk and you become short of breath? So it's really important to know, because patients sometimes can walk 30 feet, 40 feet and have heart failure, and their baseline is that they become short of breath at about 30, 40 feet of walking. And that's the best we can get them because of their low ejection fraction. Okay. The other thing that stands out is she has fine crackles in the bilateral lower lobes of her lungs. Okay. She has an oxygen saturation of 89% in room air. I'm assuming that's at rest. Sometimes you need to know that room air at rest. We know that it should be at least 92% and above. Okay. We know that her cap refill is greater than 2 seconds in her lower extremities. So we know that she's not getting good oxygenation or good blood flow or circulation to her lower extremities, and greater than 2 seconds in her upper extremities. And we also know that her blood pressure is low. It's 100/60, and that her respiratory rate is high. It's 28. Okay. So those are when you're looking at a patient and you're looking at assessment, those are things that stand out to me, go, okay, something's going on with this patient, just that information. However, when you look in your book on page 458, there's also great information that you would want to collect. And that's what we're trying to ask you in this question is, what other assessments would you want to look at for this patient? Okay. So when I look at left-sided heart failure, I would want to ask her, does she have orthopnea? Can she lay flat and not get short of breath? Okay. Which usually if they're in acute exacerbation of heart failure, they cannot lay flat. Okay. I would want to ask her, does she wake up in the middle of the night and feel short of breath, like she's gasping for air? That's called paroxysmal nocturnal dyspnea. Okay. And then the dyspnea, does she get short of breath at rest? Does she get short of breath with conversation? Does she get short of breath walking 20 feet, 10 feet, 5 feet? When does she become short of breath? Okay. Because that's going to cue me to see how extensive her heart failure is. Okay. If somebody's short of breath in bed, and their respiratory rate's 28 and their pulse ox is 89%, that's going to make me a little bit more concerned than a patient who's walking down the hall and walking 30 feet and becomes short of breath. Okay, so that this patient is definitely a little bit more critical than a patient who's walking down the hall and able to walk 30 feet and not become short of breath. Okay. A cough. Does she have a cough? A lot of heart failure patients will have a cough because they have so much fluid in their lungs, and that fluid will build up and it can cause them to become very congested. And it's a different kind of cough than somebody who has pneumonia. They have a deeper cough. This is like a cough where they're trying to clear the fluid and they can't. Okay. Does she have ventricular gallops or an S3 or an S4? Think of those things. Does she have oliguria? Okay. That's when the kidneys or perfusion is diminished. Okay. And she's not urinating as much because she's holding on to fluid. Okay. And then nocturia is another one that can occur when perfusion improves when they sleep due to improved perfusion at rest. So sometimes when a patient goes to bed all day long, they don't pee if they have heart failure. And then when they go to bed, they start urinating more because their heart starts to pump a little bit better. Okay. Does she have sluggish GI motility? Does she seem to be like where she might be constipated or things aren't moving through? Is she dizzy, lightheaded, confusion, restlessness, anxiety? So these are all things that we would want to look at. We only were given a little bit of data on this patient. Anxiety, skin cool and clammy. Does she have a decrease in her ejection fraction? And the only way that we can test for an ejection fraction is by doing an echocardiogram. So she would have to have a test done, which you learned about this week. You should have learned about this week. Tachycardia or weak, thready pulse. Does she have fatigue or activity intolerance? Can she get dressed in the morning? Can she, make meals for herself? Can she get up, get moving? So if she has an activity intolerance, that's a big sign that she could have some heart failure issues. Okay. So that's left-sided heart failure. And I would highly encourage you to learn those symptoms and those assessments because you really need to understand them. Right-sided heart failure looks a little bit different. As we were talking about, it's usually back in the peripheral vascular system. So you would see like edema, you would see the hepatomegaly, the increased abdominal distension, the JVD, okay? So you would see swollen, dependent edema. We talked about that even ascites. You might see anorexia and nausea. You definitely would see the weight gain due to the retention of fluid. Okay. Weakness, fatigue, you can definitely see. So just keep those in mind because the symptoms are different and we have to understand those. Okay. So if we go on to question number 4, do you believe her heart failure is acute or chronic? Okay. So after reading some of your information, I definitely think that the patient has an acute exacerbation of heart failure. Okay. And the reason why I come to that is because MW, all of a sudden, these symptoms occurred and she became short of breath. Okay. And you read in her basic assessment data, that she said that these symptoms just started. She was feeling fine until yesterday. Okay. So she could have had some chronic heart failure, but no symptoms were happening at that time. So I still would consider her to be an acute exacerbation of heart failure. And the reason why I say this is because we talked about it. She had a previous MI in 2012, most likely resulted in muscle damage depending on the area of the heart, which I think probably affected her left ventricle. And remember, there's a huge muscle around that heart that makes that ventricle work. So if that muscle gets damaged, then the heart can't pump as effectively. Okay. Probably cleared on the left ventricle. The left ventricle, there was a sudden increase in workload. The muscle becomes less resistant, especially around that left ventricle. Okay, very similar to rubber band. So when you use a rubber band, you sling it back and forth and the resistance is pretty strong. Okay, if we have to have some resistance on the heart, and we want some resistance on the heart for it to pump effectively. However, if the muscle is damaged, that resistance can't occur. So then you get a rubber band that won't sling back, and you won't get a heart that's going to have the right amount of resistance. So if you compare it to a rubber band, that might help you understand it a little bit better. Okay. So the heart tries to work better or work harder because it doesn't have that muscle. The muscle's been damaged, and the blood starts to back up into the lungs, and pulmonary congestion develops. And her symptoms pretty much happened very quickly. She became short of breath. She had a pulse ox that dropped, and she got crackles in her lungs. Okay. So, if we go on to question 5, what nursing diagnoses are appropriate for MW? And you're supposed to name 3. Some of you had a challenging time with this, and I would highly encourage you and recommend you, please review Dr. Horkey's presentation on nursing diagnoses. You have to understand how to use it. This is how we think as nurses. So we gather our data, which we did. We gathered all our data from this patient. Now we have to try to formulate a nursing diagnosis, a problem. So now we have to figure out the problems for this patient. This patient can have many problems, and you could state them many different ways. And the ones that I thought of was impaired cardiac tissue perfusion related to excessive fluid in the lungs or decreased contractility secondary to the heart failure. Okay. And the reason why I picked this is because her O2 sat was low. She had an 89% on room air. She had crackles in her lungs, and she verbalized shortness of breath. Okay, so she has a cardiac problem. She's got a cardiac tissue perfusion problem, and this is from the contractility in the heart. The heart is not able to pump effectively. Another nursing diagnosis, number 2, you could use is activity intolerance related to imbalance between supply and demand of oxygen, as evidenced by sudden dyspnea upon exertion, fluid in the lungs. Okay, so you could think that would be another one. You definitely think that she would have an activity intolerance. Other information you could collect for your evidence, and think of your evidence as your data, your assessment that you're collecting on the patient. So everything that you've collected, now you have to cluster that data, and you have to figure out which nursing diagnosis and what data fits with that nursing diagnosis. Okay, so you could also ask the patient some subjective data. You could say to the patient, are you feeling short of breath when you're trying to get dressed in the morning? Are you having difficulty getting your clothes on? Are you having difficulty cleaning your house? Are you feeling short of breath or fatigued just being able to walk up and down the stairs? Okay, so those are the things that you want to collect on top of this information that we just had, because all we really have is she's short of breath with exertion. Okay. Upon exertion, I should say. A third nursing diagnosis that some of you picked was excessive fluid volume related to impaired cardiac function, as evidenced by she has crackles in her lungs. So she definitely has a fluid volume issue, and that has to do with her cardiac function, okay, where her heart is not pumping effectively, okay? So that would be another one. The other information you might have wanted to collect for this evidence would be her weight. Has she gained a lot of weight in a couple days? And we all know that heart failure patients, if they've gained, 2 to 3 pounds in like a couple days, that is not weight that she just ate too much. That's fluid weight. Okay. So we would have to collect that data and see if that would be appropriate also for her. So you'd also might want to look and see if she has edema in her lower extremities. Now, a lot of patients who have left-sided heart failure end up with right-sided heart failure. So then we have 2 sides of the heart, both sides are affected, which is very common. Okay. Another nursing diagnosis that you could have used is a knowledge deficit one related to, possibly her diabetes, not knowing she's going to have a new a new diagnosis of heart failure. So she's going to have to learn a lot. Okay, she's got to learn the diet that has to go with it. She's got to learn about medication regimen. She's going to have to learn about weighing herself every day. So these things are really important, and she's not going to know any of this because she hasn't been diagnosed with heart failure. So that would be a fourth diagnosis. What I am seeing is that you're not using 3-part nursing diagnosis, or some of you are using medical diagnoses. So you do need to use your ACLY book, and you need to understand that it's important to really look at those nursing diagnoses and use a nursing diagnosis, okay? So question 6 talks about what goals do you have for MW, okay? So goals are like outcomes. I call them outcomes, goals. We have to set goals, and the goals have to be mutual with the patient also. And when I think of a goal, you want it to be, I think of an acronym called SMART. That goals need to be specific, measurable, attainable, realistic, and time sensitive, okay? So I'll say it again. The acronym SMART. They should be specific, measurable, attainable, realistic, and time. Okay. So when I think of a goal for her, and my priority nursing diagnosis would be, which is the one I thought was the biggest one, is definitely the impaired cardiac tissue perfusion related to her excessive fluid in the lungs and her decreased contractility secondary to her heart failure. And the reason why I picked that one is because if I fix her problem with her heart, I'm going to fix her activity intolerance. I'm going to fix her fluid volume excess problem also, okay? So the priority one would be that, because she has a heart problem, and I want to be able to intervene, and I want to be able to set goals around that. And the priority is, and a lot of you said about this, about ABCs or Maslow, the priority is to get her heart to pump more effectively, okay? So my goals would be that I would keep her pulse ox above 92% on 2 liters of nasal cannula within 2 hours of her receiving her Lasix. Okay, so we understand why we're giving the Lasix. It's part of my goal. I'm not saying an intervention. This is my goal. After she receives the Lasix, 2 hours later, I want to see her pulse ox come up, and I want her to be at least above a 92% on 2 liters of nasal cannula. And then my second goal that I thought of is that her lung sounds would have decreasing crackles within 2 hours of Lasix given, okay? This patient is going to receive Lasix IV push. That's going to be one of my interventions, okay? A third goal, even though we weren't supposed to do 2, I thought of a third one. Patient denies any shortness of breath with minimal exertion, like going to the bathroom, which would be about 5 feet. And you would probably see that by the end of the shift or within like 4 to 8 hours of her, of interventions that are being done. Okay. So then we go on to interventions. Okay. And there are a lot of interventions that can be done for this patient to help them. And when I think of interventions, I think of the who, what, where, and why. I also think about an acronym I learned in school. You assess, you treat, and you teach. So your interventions should kind of focus on assessing the patient, treating the patient, and then teaching the patient about their illness. So when I think about assessments I would want to be doing, I definitely want to be monitoring her vital signs every 4 hours, okay? And we always want the time. We want to know how frequently we're going to assess those vital signs, because what you're doing as a nurse is, are you going to go in every 4 hours and do it? I would hope so, because this patient is a little critical, and we want to make sure we assess her vital signs, her pulse ox every 4 hours. And if things aren't looking better, like if her blood pressure keeps dropping or her pulse ox is dropping down to 84%, then we're going to have to do some other interventions to help her. Okay. So another thing that I thought about is on assessment is we would assess her what's called a BNP, which you learned about this week. It is a blood draw that we do on a patient. And what this does for the patient is it really tells us how bad her heart failure is. So we want it less than 100, okay? I have seen BNPs all the way up into the thousands, because the muscle of the heart is so, the heart failure is is the heart is not pumping effectively. So as the heart is not pumping effectively, that BNP level will continue to go up, okay? So we want it to trend down. So we would be looking at the trending of it. And usually they draw them like every 2 to 3 days. They're not going to draw it every day. Most physicians don't because they're not going to see a huge, vast improvement. Sometimes they'll do it daily, just depending, but that's usually what I've seen. Also, we would want to monitor her electrolytes because I will tell you one of my interventions is going to be that we administer Lasix per the MD order. Okay, so we would definitely be giving this patient's Lasix IV push. Depending on the dose, that would be up to the physician. Okay. We would be applying O2 to the patient with nasal cannula and monitoring her pulse ox to keep it above 92%, which is one of my goals. We definitely would be weighing the patient daily with the same scale, the same clothes at the same time. Okay, the patient would be on strict INOs every 4 hours. We would want to be monitoring that because we want to make sure that that fluid comes off the lungs and that she starts to urinate that fluid out, the excess fluid. Okay, we would also want to monitor her lung sounds every 4 hours. And we definitely would want to be teaching the patient about a low sodium diet, okay, and her medication regimen because she's probably going to be on new medications. So this is stuff we're going to be doing every time we go in, like when she's ordering her food. We want to be there to help teach her about her diet and that she has to really keep her sodium level, sodium intake to 2,000 milligrams, okay. So those are the interventions that I thought of. I hope this helps. Question 8, I have to say, most of you did a really good job about teaching MW about her diet, about exercise when she starts to get better. So right now she's in an acute stage of heart failure. So we really can't be having her do exercise until we get her to a phase where her heart failure is controlled and her medications are working effectively. But at some point we should get her to start doing exercise. We should start teaching her about the low sodium diet, which was one of my interventions, and her medication regimen. The other thing we could teach her about is when she should call the doctor and when she needs to go to the emergency room. And those are really important things to think about. So usually we tell patients if you've gained 2 to 3 pounds in 3 to 5 days, you need to call the physician immediately because we want to try to keep them out of the hospital or keep them out of the ER. If she becomes, very short of breath and she can't breathe at rest, she needs to go right into the ER at that point. So I hope this helps. If you have more questions, please reach out. I'm here to answer them about heart failure. Okay, thanks. Bye-bye.